Today, the topic that I have selected was that medical management of vesicular reflux in children. If you look at the vesicular reflux in children, why this topic is important is that if you take children with recurrent urinary tract infections, we know it is one of the commonest bacterial infection in early childhood. If you take children with recurrent urinary tract infection, the main underlying structural abnormality causing these recurrences are the vesicular reflux. That's why this is very important. It is the commonest underlying structural abnormality causing recurrent urinary tract infection in children. We know when we look at the how this mechanism or how this happens, and anatomically there is what you call flap valve mechanism in the region of the bladder base which prevent reflux. Therefore, reflux can be primary or secondary. I will come to that a little later. And when you look at the prevalence, you can see in normal children, the prevalence is about 0.4% to 1.8%. You can appreciate that it is not a rare condition. Most importantly, if you take children who are presenting with recurrent urinary tract infection, 4 out of every 10 cases are having underlying reflux. This means that children with recurrent UTI, about 40% of them are having a risk of having underlying vesicoureteric reflux. At the same time, we know this has a genetic basis also, autosomal dominant genetic basis. Therefore, about 1/3 of siblings of a child who is had recurrent vesicular reflux is also having a risk of having a reflux. Now, as I mentioned earlier, this can be broadly divided into primary reflux and the secondary reflux. Primary reflux is an immunological event where there is a failure of ureteric tunnel to develop properly. This is a primary reflux. If you take a secondary reflux, there could be multiple causes for that. For example, if a child is having a neurogenic bladder, it can increase the bladder pressures and end up with causing secondary reflux. And also, if a child is having a posterior ureter valve, again, he has a tendency to develop increased bladder pressures and causing vesicular reflux. Another condition, I think that now we are talking a lot about the bladder bubble dysfunction, is another reason where children can develop mild degree of reflux. Therefore, this is secondary reflux. Therefore, primary reflux and secondary reflux are the two broad categories. They have their own etiologies. We look at the presentation now, how these children are present. If you take a first group of children or first group of presentation is usually antenatally diagnosed hydronephrosis. For you to antenatally diagnose as to have a hydronephrosis causing vesicular reflux is usually has to be a higher degree or grade 3 onwards. And second group of children is where we see mostly present with the childhood or urinary tract infection in early childhood or in infancy. They present either with cystitis or pyelonephritis. There is a misnomer that these children only can present with pyelonephritis. This is wrong, and some of these children with vesicular reflux can present even with lower urinary tract infections. Therefore, both upper tract and lower tract infection are non-presentation. Another important fact is that in the absence of infection, reflux is asymptomatic. The good thing about reflux, if it's a sterile reflux, is not going to harm the kidney. Therefore, reflux to cause damage to the kidney, there should be an associated infection. Otherwise, sterile reflux is not harmful to the kidney. Why this is important? Because we know reflux with upper tract infection can cause scarring. Scarring can end up with causing hypertension in childhood, and if the scarring is extensive and especially bilateral, it can cause chronic kidney damage in children or even chronic kidney disease in later life. With that background, we will go a little bit detail into reflux. We look into the grading of reflux. We all know there are 5 grades. VUR is, or vesicular reflux, is diagnosed and graded with micturating cystorectogram or MCUG. 90% of children having low grade. If you take grade 1, 2, and 3, together we call them as low grade. 90% of children are having low grade reflux. And most importantly, most children, especially with the low grade reflux, outgrow the low grades of reflux when they become around 5 to 6 years of age. 90% of children are having low grade, and most children outgrow the low grades of reflux when they reach around 5 to 6 years of age. If you look at the spontaneous resolution over time, depend on the grading of the reflux, you can appreciate that 90% of reflux or 90% of grade 1 reflux resolves or disappears when child is around 5 to 6 years of age. When it comes to the grade 2 reflux, only 75 to 80% will disappear. Grade 3 is about 50%. If you take grade 4 reflux, only 20% will resolve around 5 to 6 years of age. If you take grade 5, less than 5% have a chance of resolving it around 5-6 years of age. Therefore, 90% of children are having low grade, and most of the low grade reflux will resolve when the child reaches around 5 to 6 years of age. How we are going to evaluate this condition? At the introduction, I mentioned that this is an autosomal dominant condition, and there is hereditary and autosomal dominancy. And as we all know, any autosomal dominant condition has 2 features. One is variable penetrance, other is a variable penetrance, and the variable penetrance means that when the child can have the gene, the autosomal dominant gene, but can remain without any symptoms or any features of reflux. This is a feature of autosomal dominancy and the variable penetrance. Or this condition could be sporadic too, means that it can present without any genetic basis. As I mentioned earlier, the reason for siblings to be screened is that 1/3 of children, 1/3 of siblings of symptomatic children can have reflux. Therefore, these children can be asymptomatic. Therefore, if you diagnose a child to have a reflux, you can recommend to screen them with the basic investigation like ultrasonography, but it is not, the recommendation is that you can offer that, but there is no definite indication for you to investigate if your siblings are asymptomatic. But some guidelines, even if you look at some European guidelines, sometimes they have even recommend to do MCUG to screen asymptomatic siblings. But in our settings, we are not recommend to do invasive studies or MCUG. It's as optionally we can screen siblings when they are asymptomatic with the basic ultrasonography, ultrasound scan of KUB. Other important finding that 20% of neonates, 25% of neonates with a prenatal ultrasonic finding of hydronephrosis found to have reflux. We know when we do antenatal scan, children can be detected or we can diagnose with the hydronephrosis. 50% of hydronephrosis antenatally diagnosed will disappear when we look at 6 months of age scan. With that persistent hydronephrosis, 25% of them are having underlying reflux. Currently, we mainly use MCUG to diagnose and treat vesicular reflux, and its indications are very clear. We usually recommend with the recurrent urinary tract infection with ultrasonography findings of any underlying structural abnormality or reflux or a outflow tract obstruction. There are some relative indications. For example, if a child is a neonate, if a child neonate develop urosepsis, yes, you can do MCUG as a option, as a relative indication. Take as a relative indication to do MCUG to find out any reflux. But as I mentioned earlier, the definite indication is that if the child is having recurrent urinary tract infection with ultrasonographically evidence of reflux or any structural abnormality. What are the treatment options and outcomes? Why this reflux is important, why this respiratory reflux is important is that it causes recurrent urinary tract infections. Therefore, our goal, our aim is to prevent reflux associated UTI. How we are going to do that is depend on the grading and some medical options available. One of the basic medical options that we use is to start them on continuous low rate or low dose antibiotic prophylaxis for longer duration to prevent recurrent urinary tract infection. Continuous antibiotic prophylaxis is very effective, and the studies have shown that even it is effective as anti-reflux surgery in preventing UTI-associated renal damage in any grade of reflux. The reasons or the difficult decision is when it comes to the antibiotic prophylaxis is how long that we should use it. That is the difficult decision or difficult question to answer. When you are starting, the indications are very clear and very basics. But remember that when after you starting it, when to stop, the decision on stopping the antibiotic prophylaxis is the most difficult decision to be taken. It should be taken considering a lot of factors. I will come to that a little bit later. And other important thing is that most patients with low-grade reflux resolve as children get older, and the renal scarring rates are less than 20%. As I mentioned earlier, most of the low-grade reflux I have gone through with the percentages, resolve with the time, and even if they have developed UTIs, the risk of scarring is less than 20%. It means that even a child with the reflux, even if we develop a pyelonephritis, the chances of a scarring could be less, especially if they are having a low-grade reflux. If you look at the high-grade reflux, the story is totally different. If you take grade 4 and 5, the chances of scarring is higher, and those percentages have shown that the spontaneous resolution is also very less. Therefore, it is recommended to reevaluate children with high-grade reflux with interval MCUG, especially when it is persisting beyond 5 to 6 years of age. I have looked into few studies and quoted few important studies as being published. This is from 2010, Archive Disease of Childhood, and this is a meta-analysis done of prophylactic antibiotic to prevent UTI If you look at the results, you can appreciate that the prophylaxis has shown to reduce the frequency of urinary tract infections. But when you look at the p-value is 0.48. Therefore, that difference is not significant. Even though it has shown to reduce the urinary tract infection, the prophylaxis antibiotics, the difference is not significant when compared to the placebo group. Same meta-analysis has extended in to look at antibiotic prophylaxis with the scarring. You can see when you analyze and when you look at this data, there is no such difference between when you use prophylaxis antibiotic with the ultimate scarring, there is no effect on scarring with the prophylactic antibiotics. These are studies published in 2010, but the most recent major trial, what you call rival trial, has been done on children who is having underlying respiratory reflux. They have been put on antimicrobial prophylaxis, and there is a placebo group, and there is 607 as underwent randomization. This is the single largest study on prophylaxis antibiotic on respiratory reflux, children with underlying VUR. The results are totally different to the previous studies. When you look at the results, you can see there is a significant difference. This means that prophylaxis antibiotics significantly reduce the recurrent urinary tract infection in children with underlying respiratory reflux. The p-value is less than 0.001. Therefore, ladies and gentlemen, after this study, it has proven that prophylaxis antibiotic has a major role when we are treating children with respiratory reflux with recurrent urinary tract infection. Even American Academy of Pediatrics even recommend to maintain prophylaxis until the radiograph shows that the reflux has resolved when it comes to the grade 4-5 reflux. Another important fact is that breakthrough infections while on prophylaxis is relatively uncommon, it's around 10%. Therefore, with this evidence, in the children with the higher grade reflux, using antibiotic prophylaxis is recommended until such time they are assessed to have a low risk of recurrence. Another important fact is that the pyelonephritis and the renal scarring can occur in even older children. We know that the kidneys are growing fast during first 2-3 years of age, and if you get a pyelonephritis during that period of time when the kidneys are rapidly growing, the risk of scarring is higher. But even the older children also can, even young adults even can get a scar following a severe episode of pyelonephritis. As I mentioned earlier, the most difficult decision is to be decide on when to discontinue the prophylaxis. Therefore, if you decided to discontinue prophylaxis, or if discontinuation is elected, it would be safest in the older toilet-trained child. And also you need to look into the associated risk factors like the degree of reflux, whether it's resolving, the duration from the last urinary tract infection or last febrile UTI, and any associated risk factors like constipation, and then it will be the safest in the older toilet-trained child. Therefore, all these things has to be considered when you decided to discontinue prophylaxis. What are the prophylaxis antibiotic we use commonly? The cephalexin, cotrimoxazole, nalidixic acid, and nitrofurantoin. Those are the recommended prophylactic antibiotics to be used. In other, mainly the European countries, they use trimethoprim instead of cotrimoxazole, and I hope that we will also will be getting trimethoprim in near future for us to be used as a general use as a still is available in some parts or some uh, small stocks, but as the generally to be us to use as a prophylactic, trimethoprim will be available in near future. I decided to include a small one slide on bowel bladder dysfunction or bladder bowel dysfunction. As I mentioned earlier, it is the secondary cause of reflux due to the discoordination of the bladder construction and the sphincter relaxation. They can develop pressure inside the bladder and cause reflux. Most importantly, these children are neurologically normal. Therefore, they hold the urine and also the bowel movements for excessive amount of time and end up with having increased bladder pressures and constipation. Usually they are having a low-grade reflux with the management of bowel and the bladder. Most of the time, the reflux will be resolved with time. If a child is having bladder bowel dysfunction, there are treatment options, especially the urotherapy consists of voiding regime, and the bowel management consists of laxatives and the positioning and the regular bowel opening. And sometimes we might have to incorporate the medical management or pharmacological management introducing anticholinergic medicines. What is the place of surgery? The place of surgery is not very much when it comes to the low grade reflux, but when it comes to the grade 4 and 5 reflux, there is a place, especially when there are breakthrough infections, violent prophylaxis. High grade reflux, grade 4 5, when they are on prophylaxis and they develop UTI, violent prophylaxis, there is an indication for a surgeries. What are those anti-reflux surgeries? And one is called reflux surgeries, where you insert or where you introduce sclerotherapy to the uretrovesical junction. Sclerotherapy inject into the uretrovesical junction where the ureters are insert or are entering into the bladder. This junction we can inject sclerotherapy to reduce the reflux. What you call reflux surgeries, those are has been happening in Sri Lanka yet, but hopefully in future we will get that facility. The main surgery we have been doing in our setting is the reimplantation of the ureters. Therefore, breakthrough infection violent prophylaxis is an indication for ureteric reimplantation in our setting. And other important indications include non-compliant with prophylaxis, high-grade reflux as I mentioned earlier, and all grade of reflux who have reached adolescence with persistent reflux who desire to correct, because whenever reflux is persist, there is always a chance that the child end up with getting recurrent urinary tract infection. Therefore, those are the indications that we can use as indication for a surgery. Therefore, ladies and gentlemen, I am come to my last slide, supportive management. This is very, very important. This can prevent urinary tract infection up to higher degree. Even though we talk about the prophylaxis surgeries and those important interventions, this supportive management will have a big impact on management of urinary tract infection with children underlying respiratory reflux. Constipation is very important. If you look at children with recurrent UTI, 1/3 to 50% of them are having underlying constipation. Therefore, it is a question that you must always ask or inquire from the parents when the child presented with the urinary tract infection. We know bladder and bowel are closely related. They are going to the same levator anipelvic flow. Therefore, if one system is affected, there is a higher chance that the other system also could be affected. Managing constipation starts from the diet, the proper posture. Every child should be encouraged to at least sit for about 10 to 20 minutes twice a day after meals if they are having a constipation or less bowel movements. Make sure the child won't get or take a lot of chocolates, like foods like chocolate, where it could be a cause for a constipation, and should encourage to take adequate amount of fluid and also diet with high fiber. Adequate fluid intake is paramount importance, not only to reduce the UTI, also to tackle the constipation. Therefore, every 2 to 3 hours, child should be offered with cup of water to make sure that child is getting adequate hydration. Frequent voiding is another very important aspect. We know whenever there is a reflux, some amount of urine will go up and come back and sit on the bladder. Therefore, frequent voiding will reduce the bladder postvoidal volume, therefore reduce the risk of UTI. Therefore, every child should be encouraged to pass urine every 2 to 3 hours if they are having a recurrent UTI with the reflux. Double voiding, especially before they go to bed, they should be encouraged to void twice within half an hour interval to make sure that they won't go into bed with some amount of urine left in the bladder, which could be a good culture media for organism to grow overnight. Children with recurrent UTI with the reflux, especially reflux in boys, we recommend circumcision, especially if they develop recurrent UTIs with the underlying reflux. Circumcision will reduce risk of UTI in a significant way, because we know most of these urinary tract infections are caused by the colonized organisms like Proteus, like E. coli, Proteus, and Klebsiella. By doing circumcision, we will reduce the colonization. Therefore, these aspects are very important as supportive management of urinary tract infection in a child with underlying respiratory reflux. So, ladies and gentlemen, I have gone through a few basic concepts and important facts on respiratory reflux in childhood, and just brief you regarding how to manage them in a usual general setting. Thank you for your attention.